Welcome, Dr. Yole, sir. Good evening, sir. Good evening, sir.
Good evening. Good evening.
We are live now. We can start.
Jitu, sir.
Yeah, we can start.
Good evening, all. Welcome to the New Mumbai. Weather is pleasant in Nashik, but as well as we are also happy in New Mumbai. Not very cold, but after a long time, we could actually come out of sweaters now. So, friends, you know about this exposure is less with the sun, and we'll be also getting all vitamin D and its complication. But I don't know, vitamin D is seen everywhere. So how to, when to, how to, where to, it's all kind of these questions and answers today we'll be having, and will be, I think will be solved by the expert, that is Dr. Tushar Godbole. And I hand over mic to Dr. Jitendra Gawane, our President Navi Mumbai IIP, for the further proceedings.
Thank you, Satish. Good evening, all. Welcome to Navi Mumbai IIP. Friends, we know that some few of the magic remedies are always stated as to work in any situation. We as a young pediatricians, or I should not say myself a young pediatrician, but starter pediatricians,
You are a young pediatrician
at heart. Yeah. Yeah, so we write more medications for a single illness, and as we grow on, and then we become kind of mature, we write single medicine for many more symptoms. So that stage we want to achieve. And what is now in science is claimed that one magic remedy, such a magic remedy, is vitamin D. Now, whether it is a myth or fact, or pooled evidence, and what is the current status, we will get it from expert, as well as common questions for pediatrician, like what is a really sun exposure or timing required. I had always doubts, so I had kept a sun in my clinic here. You can see that 24/7 it gives vitamin D. So Javed and this sun always gives vitamin D to us. So thank you, Sanofi, for accepting our request to sponsor this talk and get an expert like Godbole sir from Nashik. Today's session will be moderated by Dr. Priyanka Amonkar, my colleague. She is pediatric intensivist at MGM Medical College, Navi Mumbai, and she will moderate many more such sessions in future too. So welcome, Dr. Priyanka, and I request you to start the session.
Yeah, thank you, sir. First of all, good evening, all viewers and all my senior dignitaries. Good evening, Jitendra sir. Good evening, Shahane sir. Good evening, Godbole sir. So, before I begin, I must express my admiration towards Team Navi Mumbai IIP for the colorful and wide variety of topics that they bring forward. And we get to learn a lot from all these eminent faculties. So, today's topic is also got a very colorful name. So, like we were discussing, pleiotropic effects of vitamin D. So, all of us as general pediatricians and as in whichever specialties we have heard that recently a lot of new functions of vitamin D are being discovered. So, in more than a vitamin, it is now being referred to as a hormone. So, today we'll be learning more about that from our very eminent speaker, Dr. Tushar Godbole, sir. So, let me introduce sir first. Sir is a pediatric and adolescent endocrinologist. He's the director of Harmony Health Hub, Nashik. Sir is also assistant professor at Dr. Vasantrao Pawar Medical College. Sir is a visiting consultant at various places at Aurangabad and Dhule. Sir has a lot of he has many chapters in books such as Ghai textbook of pediatrics, IEP textbook of endocrinology, and PG textbook of pediatrics. Sir has 4 national and 5 international publications to his credit. Sir is the executive board member of ISPAE. He was the editor of Maha IEP Bulletin 2015 to 16. Sir has also won the Sarla Vaishnava Award for Best Research Paper in Metabolic Diseases, IEP Delhi 2010. Over to you, sir.
Thank you.
Sir,
Thank
can
you,
you?
Dr.
Yeah.
Priyanka.
Yeah.
And at the onset, let me thank Navi Mumbai IIP, the entire team, including Dr. Jitendra, Dr. Satish, and the entire team for conceptualizing this event. And thank you, Sanofi, for providing the academic grant. Yes, it is indeed true that vitamin D is omnipresent. It's there everywhere. When we were doing our postgraduate training, or even in our undergraduate training, we were told that tuberculosis is the one that can cause any disease of any system. TB can cause anything except pregnancy. That was what we were taught. But now it's said that vitamin D can cause anything, including can cause troubles with all the systems, including pregnancy. Let me just quickly share my screen. So the today's topic that has been given to me is the pleiotropic effects, but I'll not restrict myself to the pleiotropic part of it, because vitamin D in general encompasses the skeletal system more than the extraskeletal. So we'll quickly touch upon the pleiotropy part, and then we'll move on to the latest guideline. And I have been fortunate enough to be a part of the recent IAP 2021 guideline, vitamin D. I'm one of the contributing authors for the current guideline. So I hope my slides are visible. I'm just recovering from a bad throat, so pardon my timbre of voice. So this first part, we are going to discuss about the pleiotropic function of the vitamin D, especially in pediatric age group. Yeah. So we all are aware of the effects of vitamin D deficiency. Vitamin D we get through sunlight, and due to pollution that is rampant in most of the cities of our country, the UVB rays that are specifically falling on the skin and causing the 7 hydroxy calciferol is getting filtered through various layers of pollution. On top of that, Indians have a skin type that is Fitzpatrick 4 or 5 type. So we are pigmented people. So we need more sunlight. And as against that, we often do not go out in the sunlight. People living at high altitudes, often because of the unfavorable angle of the light, they get less exposure to sunlight. During winters, especially in the northern parts of country, it has been shown that there is a wide variation in the vitamin D levels during winter and summer, and this has been documented in pediatric population as well as the pregnant females. So winter vitamin D levels are quite significantly lower as compared to summer in pediatric age group, adolescents, young adults, as well as pregnant women from northern parts of India. There are certain medications like anti-epileptics, the anti-HIV medicines, steroids, because of its specific action on vitamin D absorption and vitamin D degradation in the liver. It causes vitamin D deficiency. Rifampicin, all of us are aware that it induces the liver enzymes, thereby degrading the vitamin D levels. You need activation of vitamin D at couple of places, including the liver and the kidneys. So failures of liver and kidney will cause vitamin D deficiency. And then there are malabsorptive states such as celiac disease, where the child is unable to absorb vitamin D. What are the effects of vitamin D and what are the associations? So in science, as in medicine, we know that there is something called as cause and effect relationship. So the cause and effect relationship with vitamin D is only demonstrated with its skeletal effects. So we know for sure that vitamin D deficiency is by far the most common cause of rickets. It is also contributing factor towards low bone density, recurrent fractures in some cases, and as osteoporosis up to a certain extent is associated with vitamin D deficiency. Hypocalcemia is associated with vitamin D deficiency, and in our practice, we see a lot of neonates getting admitted with hypocalcemic seizures as a result of severe vitamin D deficiency that originates from the mother and is continued in the neonates. The other disorders, such as neuropsychiatric disorders, skin disorders, allergic disorders, or various infections, there is an association where you find that the prevalence of pneumonias is more in vitamin D deficiency, or the COVID-19 manifestations were more severely documented in patients with children with vitamin D deficiency. We know that in adults, the schizophrenia or major depressive disorders are quite common in adults with vitamin D deficiency. But however, the cause and effect relationship is not yet clear. Just to do a fair comparison, so see, a person with major depressive disorder or a person with schizophrenia is less likely to go out in the sunlight, and hence he or she might be having a coexistent vitamin D deficiency. But we don't know for sure whether vitamin D deficiency causes these extraskeletal or non-skeletal disorders. So as of now, we know that vitamin D plays an important role in the skeletal development, in calcium homeostasis, and up to a certain extent, the immunological functions of vitamin D are also being explored. All of us are aware of this. The 7 dehydrocholesterol gets converted to the pre-vitamin D3 under the exposure of UVB. So what happens if you overbathe in the sunlight? What happens if you are exposed to excessive amounts of sunlight? So what happens is the same UVB rays that cause the conversion of 7 dehydrocholesterol to pre-vitamin D3 and vitamin D3 is the same UVB that also causes the degradation. So there is no toxicity of vitamin D because of excessive sunlight exposure. But you can get excessive vitamin D or the toxicity of vitamin D through food or through pharmacological agents. So this vitamin D is then, it goes in the liver, undergoes hydroxylation, causing 25-hydroxy vitamin D. 25-hydroxy vitamin D is by far the most stable source or the most stable form of vitamin D that remains in the circulation for a long time, and it is the storage molecule of vitamin D. It is then converted to 125 dihydroxy vitamin D by an enzyme called as 1-alpha hydroxylase, coded by this CYP27B1 gene. So if you have a problem in the hydroxylase enzyme, you will suffer from a condition called as vitamin D dependent rickets type 1, where the 25-hydroxy vitamin D is available in plenty, but the 125 dihydroxy is deficient, and hence the rickets. These are multiple functions that are postulated where vitamin D contributes up to a certain extent. Vitamin D receptor is, we know this receptor for last more than 3 decades now. And vitamin D receptor is present in virtually all the cells, including your parathyroid, pancreas, your immunological cells, including your killer cells, macrophages, your skin cells, keratin, the renal tubular cells, as well as the nerve cells. And of course, they have a capability of upregulation or downregulation. And these are targeting the genes that are present in the DNA. So the vitamin D receptor and the vitamin D complex actually goes inside the nucleus and brings about some changes in the DNA, and it regulates the expression of the DNA. And these are called as the vitamin D responsive genes that are present in the DNA. And these genes are expressed in different tissues differently. So for example, T cell development happens in a particular fashion if you have vitamin D sufficiency. There are anti-inflammatory effects of vitamin D. The first line of defense, that is the non-specific immune system, the vitamin D will promote the differentiation of the monocytes into macrophages, dendritic cells, and lymphocytes. And this provides the first line of defense against various infections. With regards to the anti-inflammatory effects, so it causes reduction of the inflammatory response, and the effects are exerted by the differentiation of active CD4 T cells, and it also enhances the inhibitory function of T cells. So all of you are aware of the Th1 and Th2 responses. So the vitamin D favors the anti-inflammatory environment. I'm going to skip over a few slides because we want to discuss the more important parts of vitamin D. But vitamin D enhances the ability of the macrophages to engulf certain bacteria like tuberculosis. And in absence of adequate levels, the TB bacteria are known to trigger the TLR and also impair the production of the certain inflammatory or immunological products. So there are anti-apoptotic and anti-fibrotic effects of vitamin D. Vitamin D is known to be associated with, vitamin D deficiency is known to be associated with increased propensity towards cancer. And the main reason that is postulated is the immunological, failed recognition of these cancer cells on time by certain, there are genes coding for those the immunological cells that fail to catch the cancer in time, and as a result, the cancer spreads. So vitamin D also plays a role there. There is a strong association of vitamin D with asthma, but again, we don't know the cause and effect relationship. What we know for sure is children with asthma have higher propensity towards vitamin D deficiency, either because they are not exposed to sunlight, because they don't prefer going outside to play, and also they are on steroids, either inhaled or oral steroids, which again causes vitamin D deficiency. Kidney disorders, because of the 1-alpha hydroxylase enzyme that is present in kidneys, if there is renal failure, the activation of 1,25 hydroxylase, one hydroxylation doesn't happen. So there is renal osteodystrophy that sets in. Whether vitamin D deficiency causes diabetes, we don't know yet, but then I wish to quote a study in subsequent slides where I will show you that there is some data coming from the European countries where vitamin D is playing some role in the prevention of prevention of type 1 diabetes. So can vitamin D supplementation prevent infections or autoimmune diseases? We don't know for sure. There are studies from northern parts of India. One study I remember from my own institute, University College of Medical Sciences, UCMS, but they have shown that the duration of pneumonia, the need for ventilation, the severity of pneumonia does not get better if you supplement vitamin D. Of course, vitamin D deficiency is associated with greater risk of pneumonia, but whether the pneumonia gets better with vitamin D supplementation, that we don't know. So vitamin D fortification has been a part of national programs for many European countries. So Finland is one such country where they had a functional running national program of fortification of milk with vitamin D. And this program was going on until late 80s. And for some national policy change, they stopped supplementing, they stopped fortifying their milk or milk products with vitamin D. and sooner they observed a steep rise in the incidence of type 1 diabetes. These are the national figures I'm quoting from Finland, and they realized this in year around 2000 to 2005, and again they introduced this policy of vitamin D fortification, and now the incidence or the rate change in incidence has now stabilized. So this is one study from Finland where they have shown that temporarily vitamin D fortification and type 1 diabetes incidence go hand in hand. The moment you stop fortifying your milk with vitamin D, the type 1 diabetes incidence actually went up. If you talk about type 2 diabetes, as the latitude increases, the incidence of diabetes also increases. So the diabetes incidence is less as you go close to the equator, and as you move away from the equator, the diabetes incidence starts increasing. And it is shown that as you increase the vitamin D levels above 12 nanograms per ml, the relative risk of developing diabetes goes down below 1. So this is again a study I'm quoting from ADA, the journal of ADA, where they have shown that the risk of diabetes, the relative risk, goes below 1 when your values improve. Now coming to the current status of vitamin D in Indian children, especially the infants. So vitamin D, you might have read through the CNNS 2016 survey. So this is the national survey on child nutrition published in 2016. It reported vitamin D deficiency to the tune of 20 to 25% as a national standard. And the highest amount of vitamin D deficiency was observed in northern parts, again from Punjab. Punjab is the state with maximum vitamin D deficiency, and the lowest prevalence was noted among the fish-eating states of our nation, including Kerala and certain parts of Northeast. So where the people are eating fresh fishes, coastal areas where they eat a lot of seafood, the vitamin D deficiency has been shown to be on a lower side. However, there is a discrepancy between the CNNS 2016 data and what data has been reported from most of the premier institutes, including the ones from Maharashtra. Dr. Vaman Kadilkar and group has published multiple papers from Pune. There are papers from Ratnagiri, there are papers from Lucknow, multiple papers from Lucknow, multiple papers from Delhi, from the Dr. Marwa and group. There are papers from northern, southern parts, eastern parts, and there are multiple papers from the gynecology journals where they have reported high prevalence of vitamin D in pregnant women to the tune of 70 to 80%. And maternal vitamin D levels correlate well with the neonatal levels. So we know that Indian mothers are vitamin D deficient because they don't go out in the sunlight. Even if they go out in the sunlight, they are wearing full clothes, they are fully covered with the clothes, so their skin is not exposed to sunlight because of our modest clothing styles. So although we are a sun-rich country, the mothers from India are vitamin D deficient, and hence the neonates are also deficient. There are multiple studies that show prevalence of vitamin D deficiency in neonates between 50 to 70%. There is no national data available on vitamin D deficiency in infants from our nation. This is one study that I wanted to quote from Delhi by Dr. Anju Seth and Dr. Raman Marwa, where they studied 180 exclusively breastfed infants between the age group of 2 to 24 weeks, and their mothers were also studied. The levels, almost 50% of the mothers had severe vitamin D deficiency below 10 nanograms per ml, and similar proportion also was seen in the infants. 43% were having less than 10 nanogram per ml. In 60% of infants, 25 hydroxy vitamin D was less than 10 if the maternal vitamin D was also less than 10. So this is what I was quoting one of the studies. There's another study from SGPGI Lucknow where they have beautifully mentioned the cord blood levels and the maternal levels. They correlate wonderfully. What are the effects of vitamin D deficiency? So this is the skeletal effects now I'm talking about. We are done with the pleiotropic part of it. Now the skeletal effects, the growing bones have these 4 zones. There is one resting zone where there are inactive cartilage cells. Then there is a proliferative zone, then hypertrophic zone. After getting hypertrophied, calcium sets in, calcium, phosphorus, and protein sets in, and those cells undergo apoptosis, and these chondrocytes die, and they are solidified into a thick matrix. So this is the calcification zone, and which is later on converted to the ossification zone, where you have a balance of osteoblast and osteoclast constantly working on the bone, causing modeling and remodeling. So now where does vitamin D come into the picture? So vitamin D comes into the picture in zone 3, that is the calcification zone. So imagine what will happen if the child is growing without vitamin D. Your chondrocytes or cartilage cells are proliferating rapidly. They're getting hypertrophied rapidly, but then there is no calcification. So you have essentially a very, very flabby bone, which is full of very, very sticky and loose cartilage, and on top of that you are putting the entire body weight. So this hypertrophic zone of chondrocytes is subjected to body weight, and that has got no strength because there is no calcification, and this causes fraying, splaying, and cupping of the bones that we see on the X-ray, which we refer to as rickets. So rickets is the culmination of vitamin D deficiency because there is no calcification happening. What is the most common cause of hypocalcemia that you see in your practice? If you go through the textbooks, you will see multiple causes like hypoparathyroidism or some genetic CASR gene mutation, or there are some conditions called as hypercalciuric hypocalcemia. But in reality, in our country, the most common cause that I see in my practice, and you might agree, that vitamin D deficiency, plain simple vitamin D deficiency, is the most common cause that we encounter, and especially post lockdown, we have seen a tremendous increase in hypocalcemic seizures in infants. Infants as young as 2.5 to 3 month olds are coming with hypocalcemic seizures, and you check the baby's vitamin D, you check the mother's vitamin D, both of them are below 12 nanograms per ml. So I'm just quoting 3 studies, all from India. So one is from Mehrotra et al., Indian Pediatrics 2009. 60 hypocalcemic infants were studied. 90% of the hypocalcemic infants and 85% of their mothers were having severe vitamin D deficiency. So by far the most common cause in this case series. Again, a case series by Dr. Bala Subramania from the southern parts of our country. So 13 hypocalcemic seizures, all had vitamin D deficiency. And most important factor or most important fact that I want to highlight here is all these 13 hypocalcemic seizure, these infants had not received any vitamin D supplementation. So the lack of vitamin D supplementation in neonates predisposes them towards serious life-threatening hypocalcemias. Leave rickets. I mean, when we were formulating the current guidelines, there was a lot of debate that rickets is not common. You see rickets, maybe one rickets case in 2 to 3 months. Why do you want to subject all newborn babies to this pharmacological dose? But then it's not just the rickets we want to prevent. We want to prevent the hypocalcemic seizures. There have been multiple reports from India and abroad where infants have been diagnosed with dilated cardiomyopathy as a result of hypocalcemia due to vitamin D deficiency. So there are multiple case reports, case series that you can dig out from your PubMed, where you see that hypocalcemia is very, very common. and the common cause is vitamin D deficiency. Does maternal vitamin D have any impact on the child's bone composition? So the outcomes or the results are conflicting, but then I wanted to quote this one study from 2011. This is an Indian study from Mysore, where 568 women were delivered and their offsprings were studied for anthropometry, metabolic parameters, and their muscle grip. So 67% of the mothers were deficient antenatally, and the children that were born had smaller muscle girth at the 5th birthday and on the 10th birthday, and higher fasting insulin levels on the 10th birthday. So please remember how important it is to have vitamin D sufficiency, not just for the child, but before the conception happens. So the mother or the mothers or the ANC mothers have to be told to go out in the sunlight and sit. मराठीत ज्याला ऊन खात बसणे म्हणतात. Earlier days, ladies from the house, when they are done with their household chores, they used to go out and sit in the sunlight, and that is very, very important to prevent the vitamin D deficiency. And the maternal vitamin D deficiency has got long-term implications on the child's health, including higher fasting insulin levels on the 10th birthday. So vitamin D has got its effects on all these systems. We have seen this already. Now, how to diagnose vitamin D deficiency? So we are all aware that this 2021 guideline was released in the month of December 2021 and published in 2022. It came in the print. So why this guideline? Because we already had a guideline in place in 2017, but then a lot of data has now made available. A lot of research has been published later on. So we had the CNNS data coming up after the previous guideline. There are more number of studies available on infant supplementation, preterm supplementation, and pediatric supplementation. And we know that maternal supplementation also has got its role in preventing vitamin D deficiency in the infants and children. Plus, 2017 guideline did not specifically talk about the maternal supplementation or preterm or low birth weight, although they mentioned, but there was no provision for specific dose for separate dose for preterm or low birth weight, and sunlight quantification was not mentioned in the previous guideline. So this is the latest guideline. You can go through, and I'm one of the contributing authors. So what are the clinical signs of vitamin D? All of us are aware. Craniotabes, large anterior fontanelle, delayed dentition, congenital rickets, and recurrent chest infections are associated with vitamin D deficiency. But what are the levels? When we are talking about vitamin D deficiency, we are talking about the biochemical levels that are less than 12 nanograms per ml will be referred to as deficiency. 12 to 20 nanograms per ml is insufficiency, and 20 to 100 nanograms per ml is normal. So please remember, this is not different from the previous guideline. 2017 guideline also mentions the same. Even the global consensus guideline in 2016 also referred to the same. So vitamin D levels have not changed. Now please remember, this cutoff of 12 and 20 is for pediatric age group. This level of 12 nanograms and 20 nanograms is for pediatric age group. If you want to interpret your own report, all of us being adults, the cutoffs are 20 and 30. So in adults, they still take 20 nanograms as the cutoff for deficiency and 30 for sufficiency. Now, why this? There are multiple reasons being given. First is the PTH deflection point. There is a point below which, if the vitamin D goes, the PTH starts rising suddenly. So that happens somewhere between 30 to 20. But merely PTH deflection does not predict anything. You have to see the skeletal effects. And by far, whatever pediatric literature is available, it is shown that rickets or the hypocalcemia happens only when the vitamin D level goes below 12 nanograms in most of the studies. And that's why in pediatrics, we stick to the deficiency cutoff as 12 nanograms per ml. How do we prevent vitamin D deficiency? So now I'm just quoting the guideline and I am going to give a justification. So the guideline says all infants below 1 year should receive a daily supplementation of 400 international units per day, and doses above 400 international units do not provide any additional skeletal benefit, and doses higher than 1600 international units per day are definitely toxic. So they are warning us, the current guideline is warning us that you should give 400 to all babies starting from day 1 of life until the first birthday. And if you are worried about the side effects, of course, there are papers available that have compared 400 versus 800 versus 1200 versus 1600, and they have shown that increasing the dose above 400 does not yield any further benefit in terms of bone density, BMC, BMD, aerial bone density on the first birthday and the third birthday. Now, points to ponder here is, although the guideline mentions only first birthday, do we really stop the child from taking vitamin D after his first birthday? म्हणजे आज केक कापला आणि उद्यापासून vitamin D घेऊ नको. Does it happen? And do you expect that after his first birthday, the child will suddenly start going out in the sunlight? If it is happening, then the guideline is very well justified that after first birthday you stop. Otherwise, the context or the reading between the lines that I want all of you to do is, until the child is ambulatory and starts going out in the sunlight, you must give the 400 international units per day. So this is the extension of the current supplementation, but of course it is not in the guideline. It is for the readers to interpret and follow. You will continue this 400 international units per day until the child goes out in the sunlight. So when the child becomes ambulatory and starts playing outside, you can stop this routine supplementation. Now, this is one double-blinded randomized control trial that I am quoting in front of you. This comes from Turkey. 169 infants, they were divided into 200 international units versus 400 international units per day. The group B achieved better levels as compared to group A, and 20% from the group A had levels below 30 and 0% from group B. So 400 international units per day when given can cause vitamin D sufficiency safely and effectively. So this is data from the European Journal of Pediatrics, but the data is from Turkey. So we know that 200 international units per day is not good enough. 400 is just enough. You will still have some of them in insufficiency range, but definitely deficiency will be prevented, and that's what we want to prevent: deficiency and its effects on calcium metabolism. So 400 international units per day will definitely save you from deficiency. So this is one paper by Gallo S et al. And its extension. So the same paper they again published after 3 years of follow-up. So 132 term neonates, double-blinded RCT, divided into 4 dose regimens, 400 to 1600, and 1600 group was discontinued because of its toxicity. Many children were shown to have toxicity, and highest levels were achieved with 800 and 1200 without toxicity. So ideally there is a scope to increase your daily supplementation to 800 or 1200, but again recommendations or guidelines are based on hard facts, and this is just one study, so we cannot generalize to give 800 or 1200 to everybody, but then 400 is good enough to prevent skeletal effects. So what about preterm babies and low birth weight babies? So although 400 international units is safe, it may not be effective. And why I'm saying that? There are only 3 or 4 papers available who have extensively studied effects of vitamin D supplementation in preterm or low birth weight babies. There are guidelines like the ESPAGAN guideline that talk about this supplementation at 800, but the most of the professional bodies other than ISPAGAN, including the AAP, the IAP, they are still sticking to 400 because it is safe. So from where does this 400 come from? So again, this comes from two studies, one from Europe and one from Canada. But then these European girls or European mothers, excuse me, so these European mothers are sufficient with vitamin D versus the Indian mothers, most of them are deficient, and 400 may not be sufficient. So points to ponder here are Indian preterms may have biochemical deficiency So Indian preterm babies may have biochemical deficiency if the baseline levels are deficient. So this is one paper from US. Pardon me for this interruption, but I'm still recovering from my URTI. Really sorry about this. So this particular paper from Journal of Pediatric Gastroenterology and Nutrition, where 301 infants, some of them were VLBWs and some of them were ELBWs. 80% were deficient at 4 weeks. Then they were all started with 400 international units per day of supplementation. The VLBWs corrected their deficiency at 8 weeks and the ELBWs corrected their deficiency by 12 weeks. So the ELBWs may require higher dose and they require higher amount of time to get corrected. And these are US based. This is the US based study. The author is Indian origin, but the study is US based. So 400 international units does not cause toxicity in preterm babies that we know, but whether it is sufficient. So there's one more study from South Korea. 52 ELBW babies, cord blood vitamin D levels were checked, and a dose of 800 international units was given to these ELBW babies. 88% were sufficient at the end of the study if the baseline value was above 10 nanograms per deciliter, and only 65% were sufficient with this 800 dose if the baseline value was below 10 nanograms per deciliter. And if you keep on giving 800 international units to a ELBW baby with baseline value above 10 nanogram per deciliter, then you are likely to cause toxicity. So this study taught us two things. One is there will be some ELBW babies who will require 800 to cause sufficiency, but then there will be another set where you will cause potential toxicity. So VLBW, ELBW babies, they correct later for their deficiency, and some of them will require 800 dose. So who are those? So if you have resources, if you are working in high-end NICU where all the facilities are available and the patient is affordable, then it is advisable that you document the baseline cord blood level. If the cord blood level is less than 10 nanogram, then continue with 800 IU per day. If the cord blood level is above 10 nanogram per deciliter of vitamin D, then you are safe in giving 400 international units per day. Do we have an Indian data for this? Yes, we have. So this is Indian data from AIMS, All India Institute of Medical Sciences, New Delhi, where 96 preterm infants were studied, double-blinded RCT, comparing 800 versus 400 international units per day. Vitamin D was assessed at 40 weeks and 3 months. What was the prevalence? At 40 weeks, 38% and 66% were deficient in vitamin D in 800 versus 400. So more number of patients were deficient in 400. And at 3 months, the deficiency was 12.5% and 35%. So you see, in Indian setup, if you give 800 international units to your VLBW or preterm babies, still 12.5% will remain deficient. So there is a scope for giving 800 international units per day to your preterm, low birth weight or ELBW babies, keeping in mind that some of them will have toxicity if the baseline values are normal. So coming to the routine supplementation of children and teens, I'm coming to the fag end of my talk now. So in healthy children, we do not recommend routine testing. We do not recommend routine supplementation. Now, again, points to ponder is this is a recommendation by IAP that you did not give routine supplementation to all. But then there are papers again from metropolitan cities where girls are not exposed to sunlight. So you have to individualize to your own set of patients. Of course, you would recommend all of them to have vitamin D rich diet, including your mushrooms, including your fish, your seafood, or else go out and sit in the sunlight, failing which you will have to take vitamin D from outside. And Dr. Marwa has shown that daily supplementation of 1,000 units or 3-monthly dosing of 60,000 international units given for 1 year was found to be safe in adolescent girls from New Delhi, and none of them actually developed toxicity. In fact, they barely managed to achieve their they were barely able to mitigate their deficiency. What is real world data? Do we have any real world data that tells us that giving vitamin D to children actually does something good? So Turkey has got a universal vitamin D supplementation program in place. If I remember correctly, it is there since 2005. And government initiative is there to supplement 400 IU per day to all infants. So this government is giving. And pre-supplementation rickets prevalence in Turkey was 6%. That's quite high in 1998. And post-supplementation rickets prevalence is 0.09 in 2008. So these figures, these do not come from one paper. These come from 2 different papers, but I have put them together for your reference. So currently, the vitamin D prevalence from Turkey is vitamin D deficiency prevalence is 5%, and the rickets prevalence is 0.09%. And in India, we have our own national standard for pediatric deficiency. It is to the tune of 20 to 25%, the official figure. So here is the real world data of, this is the efficacy of national program where they have given vitamin D supplementation to infants. I'm not talking about children, only infants until first birthday, and they are able to prevent vitamin D deficiency and also prevent rickets in their own country. What is the high risk group? High risk group is children belonging to non-ambulatory states such as cerebral palsy or neuromuscular disorders, children with liver disease or kidney disease, children with malabsorption, children with long-term glucocorticoids, anti-epileptics or steroid intake or any antifungal intake, endocrine disorders like hyperparathyroidism, where I come into the picture, or disorders with extensive cutaneous involvement where you don't want them to go out in the sunlight or get exposed to dust. These are the high-risk groups where you would continue the routine supplementation of 400 international units per day. Again, points to ponder is cost and compliance. Can you ask a person with cerebral palsy or a person with nephrotic syndrome or any autoimmune condition to just keep on taking vitamin D 400 IU per day as a daily preparation? So instead, we should think of an option of 60,000 international units given as bi-monthly or quarterly. One must think of this as an economical option. What about sunlight? So the current guideline categorically mentions the amount of exposure. This is the 2021 guideline, IAP. So sunlight exposure is recommended as 17 to 30 minutes in infants and 30 to 45 minutes in older children, preferably 15 to 40% body surface area. Now remember, children, infants have higher body surface area as compared to their own weight, whereas adults have got less body surface area as compared to their weight. So if you compare body surface area to the weight, children have a higher body surface area. Hence, they require lesser amount of sun exposure. Again, the pigment also increases as the age increases, and puberty, you become a little tanned or darker. So older children require more sun exposure than the infants, and the area exposed is anywhere between 20 to 40% of body surface area. And you can go through the detailed guideline where they have given how much area you need to expose, how much percent will be contributed by the arms, the chest, the face, etc. How many days in a week? At least 5 times in a week. And what is the timing? Timing is between 11 a.m. to 3 p.m. So sakalcho kovdo un whatever have been taught to us by our ancestors or previous generations. Sakalcha kovda unat vitamin D milto. That's incorrect, because we have to go out in the sunlight between overhead sunlight exposure, that is 11 a.m. to 3 p.m. आणि हे पण याला पण बेसिस आहेत. Dr. Hari Narayan and group from Tirupati Institute, they have very nicely documented the zenith angle of the sun. So the angle made between the sun, the horizon, and the recipient, that's called as the zenith angle. So the angle and the sunlight exposure and the vitamin D generated, they have wonderfully published in their paper maybe some 5-6 years ago. So you need at least this much amount of sunlight exposure, which is impractical in most of the scenarios. IEP recommends to avoid routine use of sunscreen application, and there is not enough evidence to compare pharmacological supplementation versus sunlight exposure. My own institute, where I did my fellowship from, SGPGI Lucknow, where my colleague Dr. David Chandy and Professor Vijayalakshmi Bhatia, they had conducted an RCT where they compared the effect of 15 minutes of sunlight exposure in newborns versus 400 international units of supplementation per day. And what they found out was 400 IU per day was better than 15 minutes of sunbathing for neonates. So this study they had conducted only in neonates for first 3 months. However, we do not have any long-term data or not enough data to compare whether sunlight exposure is better or pharmacological supplementation is better. So we don't know that. This is the paper that I was quoting from Tirupati, whereas the sun zenith angle increases the vitamin D conversion from 7-DHC to your vitamin D also increases. So among these three, who do you think will get maximum vitamin D with the same amount of sunlight exposure? So the darkest fellow is going to receive the least vitamin D because the melanin is filtering out some amount of UVB rays. So darker people need more sun exposure than the fair colored people. So this also one has to keep in mind. Is sunlight good enough? So 87% of pregnant females from Uttar Pradesh were deficient despite living in abundant sunlight. This is from Lucknow. Maternal and neonatal vitamin D correlate well. Mean vitamin D levels in mothers and their neonates were 14 nanograms and 8 nanograms when they are living in rural areas of our country with abundant sunlight. And 15 minutes of sunlight exposure to infant. This is the same study that I was quoting from British Journal of Nutrition 2016, that 15 minutes of sun exposure to infants did not mitigate deficiency in most of them. So is pharmacological supplementation better than the sunlight exposure? We don't have much data, but then in this particular study, yes, it is better because it achieves better biochemical levels, and also at 9 months of age, if you compare the risk of infections such as diarrheal episodes or respiratory episodes, the infants receiving pharmacological supplementations have far less chances of recurrent infections as compared to the children who have not received pharmacological supplementation but only received sunlight. How do we treat vitamin D deficiency in neonates and children? So in neonates, you will of course not give any STOS regimen or big dose or single dose. You will always prefer daily supplementation over weekly supplementation because it provides you a steady rise in vitamin D level as compared to weekly. And oral is always preferred to injectable because the oral vitamin D supplementation has got a longer retention period. So it is retained in your body for a much longer time as compared to injectable. The injectable is distributed in the circulation very fast, and it also goes away from your system very fast. So below 1 year you will give 200 international units per day. This is the treatment of vitamin D deficiency. Above 1 year you will give 300 international units per day. The duration is 12 weeks, that is 3 months. The guideline also gives you an option of 5 doses of 60,000 international units, but please remember, not in infancy. This option of 5 doses, this is the modified STOS regimen, where you are not giving some 6 lakh or 3 lakh, you are just giving 5 doses of 60,000 international units given as once weekly dose. So maximum dose is 3 lakh units spread over 5 weeks. So this is my summary slide, and I'll summarize by saying that vitamin D deficiency is prevalent in Indian pregnant females, lactating mothers and neonates. Vitamin D levels in mothers do correlate with the neonatal levels. Vitamin D deficiency can cause skeletal and non-skeletal effects in infants as well as in children. Prevention with pharmacological supplementation of vitamin D during infancy is recommended by most of the guidelines, including our own IAP. 400 IU is enough for preterm babies. 400 IU is enough for term babies. For preterm or ELBW, there is a provision of giving 800 international units, provided you have documented the baseline level. There is no role of routine supplementation beyond infancy, but one must ensure that the child is going out in the sunlight or consuming vitamin D rich food substances. Thank you. Thank you so much.
Thank you, Tushar sir, for your excellent talk. I would just like to give a summary of what all the topics that you covered. So you first spoke on the pleiotropic part of vitamin D, where you told that apart from rickets, what are the other things it causes? Like it is so you told us that a definite cause and effect relationship is established only with rickets, low bone density, fracture, osteoporosis, and hypocalcemia.
Correct.
So the other conditions where a definite cause and effect has not been established, but still research is going on. Are areas like neuropsychiatric effects, skin disorders, pneumonia, allergy, infection, hypertension, cardiovascular disorders, type 2 diabetes mellitus, autoimmune disorders, and cancers. Then you went on to discuss regarding the basics of vitamin D, that is synthesis, functions of vitamin D, the vitamin D receptor, very much under research currently. Then you discussed regarding the anti-inflammatory effects of vitamin D, its anti-apoptotic and anti-fibrotic effects. You also discussed regarding risk of TB and cancer, asthma and diabetes mellitus due to vitamin D deficiency. At the end, you summarized by saying that it is not known if supplementation can prevent these. So that is very important. That still it has not been proven that vitamin D supplementation can help in preventing all these disorders that we discussed. Then you went on to discuss about the very important topic of vitamin D deficiency in Indian mothers and how it is leading to vitamin D deficiency in infants. You discussed about vitamin D and hypocalcemia, diagnosis of vitamin D, clinical signs, prevention, what are the doses in infants, and in so you told that until another point which was new to me was you recommended that we should continue giving vitamin D supplementation until the child becomes ambulatory and not only up till 1 year. That is something which is not yet recommended, but by IAP, but we should consider it. Then you told regarding how children and teens do not require like routine testing or routine supplementation. You told which are the high risk groups which require supplementation, such as those who are non-ambulatory children like CP, neuromuscular disorder children, children who are having malabsorption, children with liver kidney disorders, children on glucocorticoids and glucocorticoids, antiepileptic medications. You also told, lastly, you summarized regarding the treatment of vitamin D, how daily supplementation is recommended and oral is preferred. So, sir, now let us move on to the question and answer session.
Tushar,
So,
Tushar,
Yeah.
at this point, I want to ask: Are you going to take questions, or you are going to take song requests as well?
Today my vocal cords are already
So
giving me
let
troubles.
me tell the
Yeah.
delegates that Tushar is
Sorry.
excellent singer and he has won many prizes in Mahapedicon and he has won national prize in Pedicon Mumbai also. Priyanka, continue. You forgot Priyanka about this facet of
yes,
Tushar.
sir. Yes, of course. Thank you, sir, for mentioning. Okay, so sir, moving on to the question answer session, I
Yeah.
request all viewers to please put up your questions in the chat box. So I would like to ask a few questions of my own, sir. I always wondered. So, what is more important for vitamin D? Is it sunlight or is it dietary supplementation? So can one, if can you say which one is more important?
See, if you go through the evolution, we were hunters and gatherers. So we used to go out and hunt during the daytime, and whatever we could hunt, we used to eat. So we are designed to survive on both. It will not be like every day I'll be able to get a fish from the river, but I'll make an attempt to hunt something. So both things are important. Unfortunately, both of them are unreliable. In cities where the fish, there is fish farming. The fish are not natural fish are not available at many places, and I'm not sure what is the vitamin content of that pisciary raised fish. The chicken or the cattle that are eaten as non-veg, apparently we don't eat liver. The liver part that is rich in vitamin D, most of us that eat non-veg, they will relish the muscle part of it, leg piece, breast piece, but nobody eats liver. And it is the vitamin D that is present in the liver of the animal, and not the muscle. I mean, most of them. It's true for B12 as well. Mushrooms, yes, mushrooms are one important source that is underutilized. Cheese has got some vitamin D. Eggs, and non-vegetarian, I have already told, fish and crabs. So seafood is again one. But if you are a poor vegetarian like me, then you are having very, very limited options for vitamin D. So for a person who is really vegetarian and not really eating cheese or any dairy items, then you are only left with sun exposure.
So can we say that an average Indian diet is actually deficient in vitamin D?
Yeah. So we need to identify the sources and promote them.
So in that case, would you recommend? I mean, so should supplementation be something which we should, be considering for everyone, all Indians, or certain, like females, for example?
Luckily, there are some government programs that are introducing oil fortification. So whatever edible oil we use in the kitchen, now government may come up with a proposal that I mean that the proposal is already in place. The implementation is not there, but we may have our own food fortification program where cooking oil will be fortified with vitamin D. So maybe that will really help in bringing down the overall vitamin D deficiency across the country.
Yeah. Yes, sir. Yes, sir. So at the same time, isn't vitamin D the most abused supplement? So we see that, I mean, so many times in the OPD, we see that a child who's a suspected case of rickets comes and he's gone to multiple doctors and all of them have prescribed this
Yes.
60,000 international units as he's been taking it for like 9 months, 1 year.
Correct.
How long does it take for a child to develop hypervitaminosis? And how
Um,
common is it?
it's quite common. And in my setup, because I get referrals from many places, and before the patient has come to me, the patient has already visited multiple pediatricians. So I see it very commonly, maybe 2 to 3 patients in a month of vitamin D toxicity. Most of them are just biochemical toxicities and not the florid raised ICP or vomiting or pseudotumor cerebri. We have seen some of them have had irritability, polyuria, abdominal pain, and these are all signs of hypercalcemia. So vitamin D toxicity, the manifestations are of either pseudotumor cerebri because of vitamin D deficiency, vitamin D excess, or it is because of hypercalcemia where you are having abdominal pains or polyuria or irritability, hypertension. So it is quite common. And as you rightly pointed out, we forget to take the previous history into the account, that how many sachet or how many capsules has the patient consumed. Plus, we fail to take into account the multiple preparations. There are some syrup preparations, there are some capsules, there are some mouth dissolving tablets, and parents may not be able to tell you कि vitamin D था उसमें या और कुछ था. Sometimes they'll say कि calcium ले रहे हैं हम लोग, and when you ask in particular कौन सा calcium, तो कहेंगे कि हफ्ते में एक बार का calcium. So they will confuse between vitamin D and calcium. So one has to dig into the history of calcium containing or vitamin D containing products. Yeah. What was the other question? But so it's quite common. We see it commonly. And how much dose does it require? We have seen it happening with the doses of 3 lakh units also. I mean, when infants, 5 or 6 or 7 month olds have been given those sachet to be put in milk and given. So maybe 5 or 6 sachet. We have seen in infants also, they have caused a dose of 1.5 to 3 lakh unit cumulative dose in an infant. We have seen vitamin D toxicity. But beyond infancy, it's largely the mega doses like 6 lakh units when the person goes to an orthopedic surgeon and the orthopedic surgeon has given 6 lakh unit. That is the time we generally see toxicity.
Yes, sir. So while we are here, can you just briefly summarize the various preparations that are available for vitamin D?
Yeah, most of us are familiar with the weekly dose. And I'm seeing that there is a question on the same thing, that what is the scientific reason for intermittent vitamin D supplementation with 60,000 international units? So in European countries and some Western countries, there is no preparation of 60,000. They have their own preparation of 50,000, 50. So most of the data that compares daily versus weekly comes from 50,000 international unit. And for our convenience, we have converted that cumulative dose and divided by 60,000 because we in India have a preparation of 60,000 units. So the sachet or the mouth dissolving tablet or the liquid preparation like the nano preparation, we know, I'll not take any names, but these preparations are there, either liquid preparations, tablets, capsules, for 60,000. Then we have drops and those drops generally have 800 international units per ml. Most of them. Some of them have 400 international units per ml, and a couple of them I know who have 2000 international units per ml, and that is where the problem arises. If the brand gets changed from 800 to 2000 and they keep on giving 0.5 ml or 1 ml per day, then there is a chance of toxicity.
Okay, so I'd like to take a question from the chat box. So Dr. Girish is asking, on which day after birth should we start vitamin D? Day 1, day 7, day 14?
So the ideal answer is, as soon as the child has started breastfeeding, on the same day you will also start giving vitamin D.
Okay, then another question by Dr. Praveen Modi sir is TOS therapy out of practice for good?
It should be out of practice for good, but unfortunately, the children don't just go to pediatricians. They will also go to their general practitioners who are still in love with TOS regimen. They will go for their knee deformities to their orthopedic surgeons who are still in love with TOS regimen. My thesis topic, I have done a thesis on effect of fluorosis in rickets, and there as a part of that I have given 6 lakh unit injection to some of the children. So I have also partly caused this problem to some of my children, my patients. But then now, since the guidelines are in place and we know that the STOS regimen, especially the 6 lakh unit wala STOS, has got no place in treating rickets, we have better and safer modalities. Injectable vitamin D in cases of celiac disease or any malabsorption syndrome where you are not sure of the absorption, you may give 1.5 lakh units as a single injectable dose, but definitely not beyond 1.5 lakhs, and definitely not 6 lakh unit.
Yes. Currently, so the latest guidelines mention that you can give intermittent doses as well. So can you please tell in what way, if at all we have to give and we are not able to give the daily dose, then how do we give the intermittent dose?
Yeah, so this intermittent dose has been, this terminology has also been used in context for those chronically ill children, cerebral palsy or nephrotic syndrome. So, for example, we have data on nephrotic syndrome from Hyderabad, where they have compared 1,000 international units given daily versus 60,000 international units given bi-monthly, once in 2 months, and they have shown that the levels are comparable. The bone parameters, the skeletal parameters, and those calcium profiles, etc., are comparable. So by equivalent doses means that if you want to give 1,000 units per day, you have an option of giving 60,000 international units every alternate month. So that is what we mean by intermittent dosing.
Okay, so we have another question where even on frank deficit. Sorry, yes, sir.
Yeah,
Yes.
Tushar, I have one comment and 2 questions actually.
Yes, sir.
So for STOS regime, we examiners are also equally responsible, and we keep on asking every time what is STOS regime, because that's very favorite question of all examiners. And at undergraduate level, they somehow that goes in their mind that this is the treatment. Other thing is, I want to ask what is the difference between regular and nano preparation of vitamin D? And third thing is, like this 60,000 intermittent, whether going to Goa and Andaman intermittently is okay.
Yeah. So the nano preparation is the difference between nano preparation and the conventional preparation is it does not depend on the fat content of the meal, and it does not actually depend on various factors. It can actually pass through the intercellular junctions, and it is reported in couple of studies again from Dr. Marwa and group from Delhi that the nano preparations have got a better absorption, And so 33% better absorption is what has been documented. So nanopreparations are slightly better absorbed, and hence they achieve better levels with the same amount of dosing. However, we need more data on this. There are a couple of papers that are available right now, which favor the use of nanopreparation. And of course, intermittently, one must go to Goa, and not just go to Goa. One must not use sunscreens, because if Jitendra sir goes to Goa, he will take a bottle of sunscreen, and as he goes on the beach, he will apply sunscreen. So the whole purpose of going to Goa will be defeated. So one should go to Goa with a condition that while coming back, you will be fully tanned. Then only you are allowed to go to Goa. Otherwise, take Depura.
Yes, thank you, sir, for your
Yeah.
answer. So there's another question where they're asking, even on frank deficiency with radiological evidence, daily therapy is okay. So they're asking whether in case of, so does it make a difference in terms of recovery?
Yeah, so it's often a common, notion that if you're giving a large dose, it will get absorbed quickly and it will heal the rickets quickly. It doesn't happen that way. So there are studies, again, not many, but a few, where they have shown the healing of rickets. Also, they have shown that how quickly the levels correct when you give a daily therapy versus intermittent weekly therapy, and it is shown that daily therapy is better in terms of achieving the desired levels, as well as maintaining the desired levels for a longer time. So yes, when you have frank deficiencies with radiological evidence, like the book picture of rickets that comes to your OPD, you are still supposed to give daily preparation, that is preferred one. If you are unaware of the compliance, if you're not sure whether the patient will take daily preparation, then you may think of weekly preparation, but daily is always better than weekly.
Yeah, sure. And we are getting comments where they say the people are saying they are getting babies with hypervitaminosis and nephrocalcinosis. I think even this daily dosing will probably even help prevent
Absolutely,
hypervitaminosis.
because it does not cause rapid excursions, rapid changes in the levels. Yes, daily is safer.
So another question I have is, so when do we say, suppose we have a child who is not affording for investigations, we start on vitamin D supplements,
Yeah.
thinking it is vitamin D deficiency rickets. So at what point do we start thinking this is definitely not vitamin D deficiency, and now we should start thinking beyond this? What are the clues which
Correct.
should make us feel so?
So firstly, at the diagnosis, if there are any clinical pointers towards non-nutritional rickets, like if the rickets has started before first birthday, or maybe after fifth or sixth birthday, if there are any associated comorbidities, such as if the patient is on some medicines, etc., some contributing medical history on treatment, if at 4 to 6 weeks you should be able to see some radiological change on the X-ray, and at 12 weeks definitely you will be able to see radiological healing in most of them, and biological healing, at least you should see normalization of your alkaline phosphatase has started, although it has not fully normalized. But then radiological healing and alk phos returning back to normal by 12 weeks, if it is not happening, then you should think of resistant rickets. And here comes the role of documenting the levels at 12 weeks. Yeah, at diagnosis of rickets, you need not document the levels, but of course, if the patient is not responding by 12 weeks, then you must document the levels before you label them as vitamin D deficiency, because some of them may not have achieved a sufficient level, and you might want to repeat the vitamin D dosing before you label them as vitamin D resistant.
And the deformities that they have, do they,
It
go
takes,
back to absolute normal, or how long does it take?
do we have time? I can
Yes,
show you an image. I can show you the image of my own patients that have corrected within 1 year. कसं दाखवायचं आता?
You can share your screen.
Yeah. Sorry. Yeah. So if you can see this.
Yes, sir, we can see.
So this is deformity correction happened over a period of 1 year. 1 varsha. So it happens, it corrects. You just have to be patient. This took 1 year and they were told for surgery, and I resisted because I knew the diagnosis, and I was serially monitoring the intercondylar distance at every visit. I used to show them कि आता 13 centimeter है, आता 11 है, आता 9 है. So if you are documenting the intercondylar distance, or in children with genu valgum, the intermalleolar distance, if you are serially monitoring and it is reducing, you know that the deformity is getting corrected on its own. So no need to operate. One more patient I would want to show you where the deformity is corrected wonderfully. Look at this. Without surgery. This took 1.5 years. We were just sitting patiently for 1.5 years and the deformity got corrected. No surgery. Of course, there is.
It's
There
actually amazing because it looks as if it's almost impossible that it'll correct on its own looking at the child.
Correct. But of course, you have to keep on monitoring. If you see that despite rickets correction, if the deformity is not getting corrected, then please take help of your orthopedic colleagues. But then in most of them, surgery will not be required.
Okay, sir. Okay. I would. I think we have covered all the questions. I would. So, Jitendra sir, Satish sir, would you like to ask anything?
Apologies because my throat is giving me troubles today.
No, sir. I
Sorry
myself
about
have
that.
just recovered.
Yeah, otherwise,
I think. Yeah.
I would have requested one song at least. Yeah.
Thank you. Thank
A
you
lot
so
of
much.
us are and sore throat. Yeah. I would request. Yeah. So,
I
over to
request
Jitendra sir.
Dr. Amog. So before that, I request Mr. Javed to say a few words.
At the outset, I would like to thank Dr. Tushar Godbole sir for last 1.5 hours, sir. All the practical aspect of the clinical pediatrician who is having who have to face this daily challenge of vitamin D3 or address most of them, sir. So thank you very much, and I would like to thank Dr. Priyanka ma'am for moderating the session very well, and I'd like to thank Dr. Jitendra Gawane sir and all the committee members and IP Navi Mumbai pediatricians for coming on this digital event. So thank you once again. So over to you, ma'am.
Yeah. I would now like to request Amog ma'am to kindly say a vote of thanks.
Yeah, thank you, Priyanka. First of all, I would like to thank Dr. Tushar Godbole, a renowned and highly knowledgeable pediatric endo from Nasik, for this fantastic discussion on pleiotropic effects of vitamin D. And you've also touched upon the newer aspects of vitamin D supplementation. And the details of this session has been beautifully summarized by Dr. Priyanka. And sir, we thank you in spite of your very bad throat and URI, you've been so patiently answered all the questions of the delegates. I would also like to thank my colleague Dr. Priyanka for moderating this session beautifully. Thank you, Priyanka. And I would like to thank the sponsors for today, Mr. Javed Subedar and team from Sanofi for an academic grant. And last but not the least, I would like to thank the delegates for sitting with us in this late night session and for interacting with the speaker. And thank you so much for joining us today. Thank you and good night.
Good night.
Good night.
Thank you, Tushar.
Good night. Thank you all.
एक उधार रहा हाँ तुषार आप पे
Next time, sir.
करने के बाद
Thank you.
Vikram, so you are there?
Javed, before closing only, we have to see what.
No. Means if he is there, then I can share immediately, na. So, okay, no problem, sir. I will speak with.
Yeah.
Chalo.
Yeah, we will do that. Yeah. Thank you.
Bye, everyone.